Bismillahirrahmanirrahim. We will start with quote of the day. Allah does not burden a soul with more than it can bear. I'm Dr. Taimia Ayub, and today I will be presenting the topic of occupational safety and ergonomics under the supervision of Professor Dr. Saira Afzal, Dean, Institute of Public Health, Lahore. This is the lecture outline of today's lecture, which we will be following, starting with introduction, key definition, international frameworks, ILO conventions, and other international conventions, followed by occupational disease surveillance, ergonomics, workplace mental health, and special population. And at the end, we will be doing multiple choice questions. Global burden of occupational hazards. Why it matters. About 2.6 million deaths per year, according to ILO 2023, are attributed to occupational hazards. 374 million people suffer non fatal injury per year. 3.94% of the global GDP is lost due to these hazards, and 1.160 million occupational diseases per year occur. Agricultural, construction, and mining account for 60% of the fatal occupational injuries globally. Occupational risk rank fourth among all risk factors in global disease burden. Work-related musculoskeletal disorder, lung disease, and hearing loss dominate over non-fatal burden. According to WHO, only 15% of the workers worldwide have access to occupational health services. What is occupational health? According to WHO and ILO, promotion and maintenance of highest degree of physical, mental, and social well-being of workers in all occupations. Occupational hazard is defined as any exposure in work environment with potential to cause injury, disease, or adverse health outcome. Risk assessment is the systematic process of identifying hazards, evaluating risk magnitude, and determining control measures. OSHA is the Occupational Safety and Health Administration, governmental body regulating workplace safety standards. An OSH management system is the set of interrelated elements establishing policy, objectives, and processes to achieve occupational safety and health goals. So, first of all, we have the ILO frameworks on occupational safety and health. There are many frameworks and laws, starting with ILO Constitution in 1990, which started with mandate regulation of working hours, disease prevention, and living wages. Then we have ILO Convention number 155 in 1981, and then ILO Convention 187 in 2006. Also, there were in 1985 and in 2022 amendments. So, all these have been continuous improvement regarding occupational health services and how we can make it more safer for the workers. So, there are three main pillars for ILO, which are basically prevention, protection, and promotion. So, prevention to eliminate hazards at source, protection by systems, PPE, health surveillance, and promotion leads to worker well-being culture. For this, there is a tripartite approach by governments to set policy and legislation and ratify conventions, by employers to implement controls, provide safe workplaces, and by workers to participate, refuse if there is unsafe work environment, and report the hazards. So there are WHO global plans and ISO 45001 standards, which are the normative framework for occupational safety and health management. So WHO Global Plan of Action on Workers' Health from 2008 to 2017. There were many actions. Action 1 was the devise and implement policy instrument on workers' health. Action 2 was to protect and promote health in workplace. Similarly, followed by Action 3, 4, and 5, incorporating different aspects of workers' health. Then we had ISO 45001 2018 OSH management system standard. And again, it had many clauses 4, 5, 6, 7, 8, 9, 10 to specifically protect workers' health in different organizations and how it can be improved. Similarly, every country or region has their own frameworks. So for that, we have European Occupational Safety Health Framework according to European Union Directives and Strategic Framework from 2021 to 2027. the main parts of this framework includes to anticipate new risk, to improve prevention, and to prepare for health crisis. By Framework Directive 89 slash 391, Working Time Directive, and Machinery Directive. So these were the three main components. Now we come to another important aspect, which is the occupational health in lower middle income countries. What are the challenges, gaps, and opportunities? So the main opportunities for occupational health is ILO OSHA 2001 guideline adoption, which is the low cost management system framework. Then we have community based OSH promotion and task shifting models, mobile health or mHealth tool for hazard mapping and surveillance, South South cooperation like BRICS or OSH networks, World Bank and donor funded occupational safety and health capacity building programs. Now we come to the challenges which are faced by occupational health sector in lower middle income countries. Large informal economy, for example, in 60 to 80% in sub-Saharan Africa and South Asia is informal economy, which is outside the regulatory reach. Inadequate occupational safety health legislation, enforcement capacity, and trained inspectors. Limited occupational health services, high burden of pesticide poisoning, silicosis, musculoskeletal disorders in agriculture and artisanal mining, child labor and forced labor, weak surveillance, underreporting, and poor data system hinder evidence-based policy. Now we have examples from Pakistan and the neighboring countries how they are working to improve the occupational health sector. So there are many examples, but I have chosen only a couple of names, which from India includes Factories Act 1948, which is one of the most important act, and it was amended further in 2016. Then we have Mines Act in 1942, 52, and Plantation Labor Act in 1951. These are only the few highlights. For Pakistan, we have Factories Act 1934, particularly focusing on provincial, that was before partition. Then there is Punjab OSH Act 2019, Khyber Pakhtunkhwa OSH Act 2021, and similarly EOBI and Workers' Compensation Acts. So, how occupational health hazards are classified in these acts? They are done through systematic identification framework by, for example, labeling them as physical hazards, which includes noise, vibration, heat stress, and radiation, or extreme pressure. Then we have chemical hazards by dust like silica, asbestos, solvents, heavy metals, pesticide, carcinogens. Then we have biological hazards. Sorry, biological hazards, which include bloodborne pathogens, zoonosis, healthcare associated organisms, and like that. Ergonomic hazards, which includes repetitive motion, awkward postures, manual handling, and contact stress, along with vibration. Psychosocial hazards, which includes work-related stress, burnout, harassment, violence, shift work, and job insecurity. And finally, we have safety hazards like slip, trip, fall, mechanical hazards, confined spaces, electrical, fire, and explosion risk. So, this is again a very important figure which has been explained previously also, but it is good to go through it again, which is the hierarchy of hazard controls. So, it starts with the elimination, which is to physically remove the hazards. For example, remove hazardous chemical from process. Then there is substitution, replace the hazards with safer alternative, for example water based paint instead of solvent based. Then we have engineering controls, which is isolate people from hazard, for example ventilation system, noise enclosure, and guarding. Then we have administrative control, change how people work. For example, job rotation, training, safe work procedure, permits, etc. And finally, we have PPE, which is protect the worker, but it is should be the last resort. For example, respirator, gloves, hearing protection, and goggles. So it is a misconception in our part of the world and in our context that PPE is the best thing which can protect the worker. Unfortunately, in the hierarchy of hazard control, it is the least important, and it should be the last resort. It should not be the first thing to do. The first thing and the best is elimination or substitution. Now we come to occupational risk assessment process, which has identity, which means to identify hazards, then do risk assessment, then apply control measures, then implement and monitor, and at the end, review and improve the process through regular audit, incident review, legal compliance, and so on. This is the occupational disease surveillance pyramid. How it is goes. So we go from the bottom, which includes the unreported and informal sector, which is the base, and it is these are very much large a number of cases. Then we have those which are clinically diagnosed, then we have those cases which are compensated cases, and finally we have those cases which are actually reported, which are very less as compared to the actual number. Now we come to reporting barriers which are present in lower middle income countries, which include lack of disease registries and ICD-10 coding capacity. Workers fear job loss if reporting injuries, employer pressure and lack of compensation systems, informal worker entirely outside reporting systems. Another important aspect is workplace mental health and psychosocial hazards. Uh, According to estimates, about $1 trillion lost of productivity per year due to psychosocial and workplace mental issues. 15% workers with mental disorders at any time are present, and 12 billion working days lost due to depression or anxiety per year, and about $4 return for every $1 invested in mental health. So it is very high return sort of investment. So there are WHO guidelines in 2022 for organizational intervention, manager training, and individual support, which are evidence-based hierarchy. Similarly, we have burnout in ICD-11 classification, and then ILO Convention 190, and all these have incorporated burnout or mental health or workplace health in their classifications and frameworks. So there are few special populations which are more vulnerable as workers for different physical and mental issues, which includes women workers, migrant workers, informal workers, young workers which are less than 25 years of age, very old workers more than 55 years of age, and healthcare workers. So as we can see around, we can easily find examples of all these populations, and they are very much vulnerable to more hazards as compared to the main group. So, what are the major occupational diseases, and what is the evidence? As you can see, the major occupational diseases according to ILO 2023 is cardiovascular, which is due to work stress, followed by cancer, occupational cancer category. So these are two main deaths which are being reported by ILO. Similarly, we have silicosis, asbestosis, occupational asthma, noise-induced hearing loss, and work-related cancer. So these are different categories, and among them, cardiovascular and cancer are the top ones. So, worker compensations and legal rights. According to international standards and national systems, there are core worker right in occupational health and safety measures, which is right to know, right to participate, right to refuse, right to compensation, and whistleblower protection. Again, we come to personal protective equipment and chemical safety, which is according to globally harmonized systems in UN 2003, which includes respiratory protectors through N95 mask and so on, hearing protection through proper hearing noise cancellation, headphones and stuff like that. Then we have skin and chemical protection through proper rubber gloves, and PPE program elements protection through all of incorporating all of these. So there are emerging hazards and future challenges in occupational safety, which includes digital and data AI-driven work, climate change and occupational health, nanotechnology hazards which are becoming very common, pandemic preparedness for the next pandemic, uh, economy and remote work, and finally Industry 4.0 or automation. These are some of the challenges. Now we come to another important portion of the presentation, which is the ergonomics and setting up of occupational health services. So, what is ergonomics? Ergonomics is defined as is the scientific discipline concerned with the understanding of interactions among humans and other elements of a system, and the profession that applies theory, principles, data, and methods to design in order to optimize human well-being and overall system performance. So there are different parts or different types of ergonomics, which includes physical ergonomics, like anatomical, anthropometric, and biomechanical properties related to physical activity, concerns posture, manual handling, repetitive movement, MSDs, workplace layout, and safety. Then we have cognitive ergonomics, which includes mental processes like perception, memory, reasoning, motor response, as they affect human system interactions, concerns mental workload, decision making, human error, and training. And finally, we have organizational ergonomics, which is the optimization of socio-technical systems, structures, policies, and processes. It concerns teamwork, telework, participatory design, shift work, quality management, and OSH culture. So the main key principle is that ergonomics is proactive. It is basically preventing harm through design, not treating injury after the fact it has happened. So workstation and workplace ergonomic design. About 37% of the delis from work attributable to ergonomics, 1.7 million upper limb musculoskeletal disorders per year in Eurofund, 54 billion US annual cost of musculoskeletal disorders, and 4:1 is the ROI of ergonomics intervention. Work related musculoskeletal disorder, which includes, according to classification, mainly low back pain, carpal tunnel syndrome, rotator cuff disorders, neck and shoulder disorders, epicondylitis, and so on. So there are three aspects of public health which can be applied to them, which is primary prevention, secondary prevention, and tertiary prevention. In primary prevention, we have engineering control like workstation redesigning, job rotation and work rest schedules, pre-placement ergonomic screening, training on safe manual handling technique. Then, with secondary prevention, we have early intervention and diagnosis. Symptom surveys, for example, Nordic musculoskeleton questionnaire is an example, periodic health surveillance and screening, early physiotherapy referrals pathway. And finally, we have tertiary prevention, which includes graduated return to work, modified duties, multidisciplinary functional restoration program. So there are different models of occupational health delivery and staffing structures, which includes enterprise-based occupational health safety, which is in-house service within a large organization. It should include physician, nurse, hygienist on staff. It leads to a very much expensive burden on that particular organization. Then we have group and shared service, in which multiple small organization or industries share a contracted occupational health team, which is cost effective and common in some parts of the world. Then we have insurance based or fund model, in which workers compensation insurer funds and provide occupational health safety incentives, incentivizes prevention. Then we have public sector or national OHS, in which government run clinics for workers without enterprise services. This is common in India and also in Pakistan. Then we have community or primary care model, in which integration of occupational health into primary care, which is recommended by WHO for lower middle income countries. It leads to training of primary healthcare providers in basic occupational history, musculoskeletal disorder management, and referral pathways. So, a common multidisciplinary occupational health and safety team should include occupational physician, occupational health nurse, industrial hygienist, safety officer or engineer, ergonomist or physiotherapist, occupational psychologist, and OHS administrator. So this is a basic practical framework how to set up an occupational health service. First of all, as always, need assessment is done. Then legal and policy framework of that particular area is should be dealt with. Then design service model, followed by physical infrastructure, and then equipment and consumable are purchased, followed by health service surveillance program, And emergency preparedness, and finally monitoring, audit, and review of these services are done on regular basis. So this comes to an end of our today's presentation. Now we will be doing a multiple choice question. So we come to the first multiple choice question, which is, which of the following best reflects the core principles of ergonomics? Treating musculoskeletal disorders after injury. B. Designing work systems to optimize worker well-being. C. Providing PPE to all workers. D. Conducting periodic medical examinations only. Or E. Compensating workers for occupational diseases.
B.
B.
Yes, it is B. Yes. A textile factory reports a high prevalence of low back pain and repetitive strain injuries. The Occupational Health Safety team recommends redesigning workstation and introducing adjustable seating. This interventions falls under ad- administrative control, PPE, engineering control, substitution, or elimination.
B.
C.
Yes, it is C, engineering control.
C.
According to global burden estimates, which of the following contributes most significantly to non fatal occupational disease burden? Infectious disease, occupational cancers, musculoskeletal disorders, cardiovascular disease, or acute injuries?
D.
No, for non-fatal, sorry, for non-fatal category, the most global burden, according to global burden, which contributes to the main DALIs, is uh, musculoskeletal disorders. So it's C. During a workplace assessment, a safety officer identifies silica dust exposure, estimates its severity and likelihood, and categorizes it as high risk. This step corresponds to hazard identification, B. Risk assessment, C. Risk control, D. Monitoring and evaluation, or E. Incident investigation.
B.
Yes, it is risk assessment because they have categorized it. In a rural district of Pakistan, most workers are in the informal sector with no access to formal occupational health and safety. The health department integrates occupational health into primary care services. This model is best described as enterprise based OHS, insurance based occupational health safety, public sector specialized clinic, community or primary care model, or E private corporate occupational health and safety.
D.
Yes, it is D, community or primary care model. Which of the following is an example of psychosocial hazard? Exposure to benzene, excessive workplace noise, shift work causing sleep disruption, D, repetitive wrist movement, or E, ionizing radiation.
C.
Yes, it is C. A worker with early symptoms of carpal tunnel syndrome is identified through periodic screening and referred for physiotherapy. This represents primary prevention, secondary prevention, tertiary prevention, primordial prevention, or rehabilitation.
B.
Yes, it is secondary prevention. A factory replaces a toxic solvent with a less hazardous water-based alternative. This is an example of elimination, engineering control, administrative control, substitution, or EPPE.
Substitution.
Yes, it is substitution delta. This is the answer key. This is the YouTube link where this video will be uploaded. And thank you very much for listening.